Good evening, everyone. I'm Dr. Parul Jindal, the Chief Coordinator for today's session of this PG online class, and along with my co-coordinator, Dr. Vijayanti, Assistant Professor from JIPMER Pondicherry, I welcome all of you today. We know that WHO estimates that 65 to 75% of pregnant women in India have anemia, and nearly half of them have global maternal death due to anemia, which occurs in the South Asian countries. Along with the physiological changes in pregnancy, the anesthetic implications of anemia in pregnancy stems from the adverse effects of decreased tissue oxygen delivery. So we'll review this today in a long case, but before that, let us invoke the blessings of Ma Saraswati.
The audio was not heard.
Yes. So with the blessings of Ma Saraswati, we start this program. May I now invite our Honorary Secretary, ISA National, Dr. Bajwa, to please share his views.
Thank you, Dr. Parul. I think we must be knowing that old times when there was a cassette hota tha, when you keep playing in the recorder, so that sound keeps on going. Now next time we will play a very good Saraswati Vandana. We will record it in a new manner so that it will give us a good. It's difficult to play every time. And welcome all the respected seniors and dear friends. Welcome to another edition of PG online class. Today, I think we are touching many new milestones. All the cases, long cases have been covered in one section. By the time I think we will be starting with the webinars and seminars rather, the way the PG students present during their postgraduate classrooms, the seminars, the spot diagnosis, the long cases, short cases have been covered to a good extent now. Rather than going for the online classes by the teachers themselves, we will be doing with the students presenting the class with the moderators, helping them and questioning them about that particular class. So that is the idea from the next month onwards. Maybe another after 3-4 cases, 3-4 classes, we will be doing that thing. I think that's the way to go forward. So to instill the confidence, to make the education better for our PG curriculum. And that's the way to make it a more uniform throughout the country. So without wasting time, I thank everyone for attending these classes. And I think you should disseminate these messages to all your PG students, also the colleagues throughout the country, so that they can attend it. And later on YouTube also, you can go to ISN HQ at YouTube and you can always watch it later on whenever you get time. So I hand over the mic back to Dr. Parul to start the proceedings.
Thank you so much, sir. Just before we start with our case presentation, a few things to be remembered. Please keep your audio and video muted while the lecture is going on. After that, you can post your questions, your queries onto the chat box. We are live. The topic is also available on the ISA website after it is over. And in case after the case is done, we'll ask you for your questions also. And you can share your experiences. So without wasting much time, may I call upon my co-coordinator, Dr. Vijayanti, to introduce our chairpersons.
Good evening, respected faculty, my dear colleagues and dear residents. So I take great pleasure in welcoming the chairpersons of today's class. So first I welcome Dr. Swati Chabra. Madam has done her MD, DNP and Fellowship Neuroanesthesia from University of Toronto. Currently, Madam is working as additional professor at AIIMS Jodhpur, and she is a member of the Education Committee of the Society of Neuroanesthesia and Critical Care USA. Madam has also received Proficiency Award from ISA in the years 2021 and 2019. So Madam has over 60 plus papers and 6 book chapters to her publication account. and her fields of interest include neuroanesthesia, acute pain management, and medical education. We welcome you, madam. So next I would welcome Dr. Bharat Phaliwal. Sir has been working as additional professor at AIIMS Jodhpur, and he has so many achievements to his cap, and these include the first prize poster competition at SARC 2017 Colombo, and Sir has got fellowships in pain management from CAPSI and Daradia, Kolkata. Sir is also AHA certified BLS ACLS course instructor, and he is a member reviewer board of 3 journals, and he is also a lifetime member of ISA, ISSCM, ISSP, AOA, RSACP, IDA, and IACTA. Sir has been the Honorary Secretary, ISA Jodhpur City from 2021 for 2024. And he's also an Executive Committee member at RSA and City Branch of Scientific Committee of ISA and Executive Committee of ISSCM. He has over total of 50 publications, and his areas of interest include intensive care management and interventional pain. So I take great pleasure in welcoming you both, sir and madam. Now I also welcome the speakers for today, Dr. Dhanlakshmi and Dr. Gopal Sarkar. They'll be presenting the case on anemia and pregnancy. So they are from James Jodhpur. Over to the chairpersons.
Thank you so much for the kind introduction. And as aptly said by Dr. Parul in the beginning of the session today, this is a long case for the postgraduate examinations for their MD or DNB exams. And this is very apt because it's very common to see patients, pregnant patients with anemia in our society. And these could be for operative delivery, maybe emergency or elective. So it's very pertinent to discuss these very important issues, which will help not only in the examination, but take-home messages from today's case presentation will also be helpful in the clinical management of these patients. So myself and Dr. Bharat will be moderating the case discussion as it will be presented. So we'll pause the presenter as and when required and take the questions at the end as well. And then the discussion forum will be open to all the participants here. So I request Dr. Dhanlakshmi to please share the case presentation PPT.
Yes, ma'am. Good evening to one and all present here. Ma'am, can I start?
Yes, you can start with the case presentation.
Yes, ma'am. So we have a 19-year-old female patient, Mrs. ABC, hailing from Pali, who has studied 10th standard, and she is a homemaker. Her husband is Mr. ABC, who is 25-year-old, and he is a construction worker by occupation. She presented with history of amenorrhea for 9 months, complaint of easy fatigability for the last 1 month, and complaint of swelling in both the legs for the last 1 month. History of presenting complaints. She's a pregnant lady at 38 weeks of gestation with spontaneous conception, presented with complaints of giddiness, lightheadedness, and easy fatigability since 1 month, which increased on physical activities and relieved on rest. And also presented with complaints of swelling in both the legs since 1 month. This aggravates on physical activity and standing and relieved with overnight rest and foot end elevation. And there is no history of exertional dyspnea or palpitation or chest pain or orthopnea or PND. There is no history of evening rise of temperature or cough with expectoration or hemoptysis. No history of generalized body swelling or headache or blurring of vision. There is no history of bleeding PV, bleeding per rectum or melena. There is no history of fever with chills or burning micturition or decreased urine output. And also there is no history of jaundice or no history of any drug intake.
So Dhanlakshmi,
Yes.
I would like to ask here, what provisional thoughts you have in your mind after going through your positive history?
Yes, sir. She's a 19-year-old female patient who presented with complaints of fatigue and swelling in both the legs. So with this positive history, my differential diagnoses are anemia, and also it can be because of infection. First thing is basically pregnancy itself can have these symptoms. It can be normal in pregnancy. Any acute infections can cause easy fertility, and chronic infections like tuberculosis can also have these symptoms, and also
Metabolic
any metabolic disorders
ailments like diabetes mellitus or like
So-
infectious causes, as she told, then it can be due to any
anemia and also malignancy.
So,
These
So
are the
why have you asked for these pertinent negative histories? Do you also suspect some systemic or cardiovascular or some
Yes.
involvement like that?
Ma'am,
And
we have-
what is the basis of all these negative histories you have asked for?
Yes, ma'am. Ma'am, we have asked for the history of exertional dyspnea, palpitation, chest pain to rule out congestive heart failure. Again, that can also present with history of generalized weakness and fatigability along with swelling in the legs. So this patient doesn't have any symptoms like palpitation, chest pain or exertional dyspnea. So this rule out any cardiovascular causes like congestive heart failure or valvular heart disorders. And then a history of evening rise of temperature, cough and expectoration rules out tuberculosis, which can also be a cause of these symptoms. Generalized body swelling, headache and blurring of vision to rule out hypertension and CKD in this patient. Again, bleeding PV or bleeding per rectum to rule out bleeding causes of anemia. And fever with chest, burning with urination to rule out any acute infections and UTI. History of jaundice, again to rule out hemolytic causes of anemia, and a history of any drug intake. By that we can come to know if patient has any comorbidities for which she is taking any other medication, and also some drugs are implicated in causing anemia.
anemia.
So to rule out that.
All right, you can go ahead.
Come to history of present pregnancy. In the first trimester, UPT was found positive 2 weeks after she missed her period. And she had only one antenatal checkup. There was no history of excessive vomiting, bleeding PV or pain abdomen or fever with rash, exposure to radiation or any drug intake. In the second trimester, quickening was felt at 20 weeks. There was no history suggestive of gestational diabetes, hypertension or thyroid disorder. There is no history of bleeding PV or pedal edema in the second trimester. And iron and calcium tablets were taken irregularly.
so any specific regarding pedal edema in second trimester?
So this patient, she didn't have any pedal edema in the second trimester. She developed it later. But physiologically, in
So normally during pregnancy, there is pedal edema because as because of the gravid uterus increase in the size, it causes compression on the venous structure. So there is less return of blood to the heart, and there is the increase in the capillary pressure, causing an increase in the leading to pedal edema. Or sir, there can be pedal edema can also be due to any heart disease like congestive cardiac failure, or it can be due to CKD also.
What about PIH? By definition, when you label it, is it the second trimester?
So pregnancy induced hypertension is labeled after 20 weeks of
So it lies in the second trimester period only.
yes,
Yes, sir.
Okay. Go ahead, please go ahead.
In the third trimester, there was no history of bleeding or leaking PV or discharge PV or pain abdomen, and active fetal movements were felt.
So based on this obstetric history throughout the 3 trimesters, what could you make out? What was the significant part arising out of history?
Ma'am, first thing is the patient didn't have frequent antenatal checkups. She was not a booked case. So she failed to follow up and take regular medications like folic acid and iron therapy. Iron therapy she has taken, but again irregularly. And also antenatal scans or also not done. So it gave inference that
she was
is not
non-compliant to her follow-up, and she was not on regular, like the medications were irregular.
So what do you think could be the cause of this non-compliance with specifically the iron tablets?
Ma'am, mostly non-compliance taking iron tablets can cause gastric irritation, vomiting, gastric irritation, and like mostly that is the reason patient tend to forget, like don't take the iron medications. And at most
Another
of the
thing
time,
could be unawareness about the importance of taking iron. So we'll discuss the importance as we go further down the presentation. And if there are no more questions from Dr. Bharat, we can move forward.
Ma'am, can we take 2 questions which have come up for the history only, with your permission?
Yeah, sure.
Yeah, sure.
So the first question is, which drugs cause extreme tiredness or edema?
tiredness and edema.
Yes.
You can at least name drugs that causes some sort of anemias.
Sir, drugs mostly the drugs that are causing which are causing like less absorption of iron, or like antithyroid drugs, then it can be due to like drugs like carbamazepine. Then antithyroid drugs are told sometimes phytates and tannins. These things cause less iron absorption, so this can go into cause iron deficiency anemia, which causes the symptoms. And so sometimes pedal edema can be caused due to sometimes calcium channel blockers, that also can cause pedal edema sometimes.
And what questions will you ask a patient to find out about worm infestation?
Ma'am, we have asked about the history of worm infestation in the past history.
Okay, but what questions will you ask the patient? That is what they want to know. How did you come to the conclusion? Yeah.
Worm infestation, we can ask by history of any passage of frank worms in the stools, or
Yes.
perianal itching can be there.
So just a request, please do not use any abbreviations for the audience, like CBC, PV, or PIH. Please use the full forms. Thank you so much. Ma'am, please.
Okay, go ahead with your further history.
Yes, ma'am. Marital history, patient is married since 1 year, non-consanguineous marriage, and there is no history of contraceptive use. Menstrual history, she attained menarche at 14 years of age. She had regular cycles of 28 days with bleeding for 4 to 5 days with normal flow. There was no history of menorrhagia or dysmenorrhea, and LMP was October 25th of 2022. Past obstetric history, she is primigravida. There was no history of abortions. LMP was October 25th of 2022, and estimated date of delivery is August 2nd of 2023. Past history, there was no history of diabetes, hypertension, tuberculosis, jaundice, no history of epilepsy, asthma, or cardiac disorders. There was no history of previous surgeries or blood transfusion, and there is no history of hematological disorders or worm infestation. Family history, there is no history of diabetes, hypertension, or malignancies, repeated abortions, multiple pregnancies, or congenital anomalies in the family. There is no history of jaundice or repeated blood transfusions in the family. Also, no bleeding disorders in the family.
How the history of concomitant illnesses is significant in this case? Any history of multiple pregnancies or any comorbidities, how does it has an implication on the present pregnancy?
So
in case of multiple pregnancies, like when especially which is pertinent to Indian scenario, like the space between 2 pregnancies is very less. So what happens here is the iron stores get depleted. So this is a very this is a major cause in which leads to one cause of anemia. And the other histories that we have taken to rule out, such as a repeated history of abortions, which is very specific in case of sickle cell disease, where we see multiple repeated abortions, multiple pregnant and congenital anomalies. Obviously, sir, when we are suspecting any congenital anomalies,
Folic acid deficiency, anemia. That can cause
congenital anomalies. And
not only sickle cell anemia, but also other autoimmune syndromes like APLA, antiphospholipid. All these things can also lead to frequent
SLE.
abortions, SLE. But the ultimate thing is that multiple abortions will lead to depletion of iron stores.
Yes.
And
yes.
obviously that will be another burden. And also the psychological aspect of repeated abortions would lead to inadequate oral intake by the patient, because she's mostly stressed out, not eating enough, or maybe the socioeconomic status is such that diet is inadequate, and to top it with inadequate intake of irregular intake of the supplementation.
Yes.
One more concern is that several compensatory mechanisms comes into play in the physiological part of pregnancy. So if patient is having multiple comorbidities, it are going to affect the extent to which this compensatory mechanism will help out. So the tolerance to the physiological changes will be affected with the presence of other comorbidities. Please go ahead.
Just one thing more, how will you rule out these autoimmune diseases? I see this in the chat box also. Based on history and family history and personal history, how do you rule out autoimmune diseases?
Hereditary disorders like sickle cell anemia, ma'am.
So there are like multitude of autoimmune diseases, right? So how would you rule out based on history?
Autoimmune disorders, again, they can be connective tissue disorders. Again, easy fatigability can be there. Multiple joint pains.
Yes.
Yeah. So joint pains were not seen in this patient, and also usually with the common autoimmune diseases which we see, which affect the pregnancy adversely, are APLA, and that would lead to history of abortions. Even if the marital history was she was married since 1 year, but she might have some history of abortions in between.
Moreover, there are some certain other manifestations like other systemic involvement in the form of skin lesion or some amount of bleeding disorders, or so these may be manifested in the prenatal medical history. So no such history was reported.
So you can rule out.
So clinically it's ruled out. There are less chances that these may, because many autoimmune disorders do precipitate during pregnancy times. So, but the chances, incidence is less likely if the pre-pregnancies they do not have manifested any of such manifestations.
Okay, you can go ahead now.
Yes, ma'am. Personal history: patient takes mixed diet, has regular bowel and bladder habits. She has no addictions. Her sleep pattern is normal, and her appetite is reduced.
Mixed diet, what do you mean to say? Is it they consume vegetarian food only, or
both vegetarian and non-vegetarian?
Does that has any significance?
Yes, in case of only vegetarian diet, there can be iron deficiency anemia as well as B12 deficiency and folate deficiency anemia can also happen.
B12 specifically.
B12 deficiency, sir. Coming to general physical examination. On examination, the patient is moderately built and nourished. She weighs 56 kgs, height is 146 centimeter, and BMI of 26.29 kg per meter square. Pallor is present, and bilateral mild pitting pedal edema is present. There is no icterus, cyanosis, clubbing, or lymphadenopathy. JVP is not raised. Skin looks pale, and nails has vertical ridges. and there is no varicose veins, and thyroid and breast examination appears normal. Spine examination is also normal.
So anything specific why you about the nails? You said that vertical ridges on the nails. Does it indicate something?
So
Yeah.
again, in iron deficiency anemia, there can be changes like platinichia and vertical ridges can be there.
Spooning of nails.
Spooning of
Koilonichia.
So does it indicates to the extent of or severity of the anemia? You can go back to the slide. So is there anything correlated to the severity of anemia, the nail changes?
Not sure, sir.
So so vertical ridges are the initial manifestation. With progression of anemia, there may be a platinichia, and finally with increasing severity, there may be spooning of nails or koilonichia.
Yes, sir.
Anything with specific to your JVP or dilated veins, you why you
The
commented on
JVP,
these?
as actually it indicates like congestive heart failure, mostly right heart failure, where there will be raised JVP, there will be pedal edema, and signs of ascites can also be there in case of right heart failure.
In this patient, it is
In this
not
patient, it
raised.
is not there, sir. So it's indicating there is negative history, like no heart failure is not there.
Okay, please
So
go.
it supports your history, which you asked to rule out the failure, congestive cardiac failure. So
Yes.
this clinical finding supports your negative history, right?
Yes.
Okay, go ahead.
Vital signs. Pulse rate was 98 beats per minute, regular in rhythm, normal in volume and character, and felt in all peripheral pulses are palpable. Blood pressure is 108 by 60 millimeters of mercury, measured in the right upper arm in sitting position. Respiratory rate is 20 per minute and regular, and temperature is normal.
So do you find, please go back to the previous slide. So we see that there is a slight increase in heart rate and the blood pressure. There is a some discrepancy, and respiratory rate is 20 per minute. Do you want to comment on this in the light of patient's clinical condition?
Yes, ma'am. Like since these are all the physiological changes during pregnancy which happens, mostly what happened here is like first the blood pressure. Blood pressure is we can see that there is a gap between the systolic and the diastolic. There is a reason for this wide pulse pressure because of there is an increase in the cardiac output during pregnancy. So that leads to this wide pulse pressure. Then obviously these are then tachycardia, the heart rate is increasing. These are all done to meet the oxygen demands of the patient, the transfer of oxygen to the tissues. So these are all compensatory mechanisms which work, which happens during pregnancy. Then there are the changes in the respiratory parameters, like there is increase in the respiratory rate that we are seeing here, and there will be increase in inspiratory capacities, inspiratory reserve volume, and inspiratory capacities, and there will be decrease in the expiratory reserve volume. There will be decrease in the like FRC, functional residual capacity. So these are all mostly the changes, systemic changes that happen during pregnancy, which is being seen here.
Ma'am, should we continue?
Dr. Swati? I think we can take a question while I think they've had some
Yes,
internet
sure,
connection. Can we take this question?
Sure, ma'am.
What should be the minimum hemoglobin for blood transfusion in pregnant patient preoperatively?
Ma'am, actually, it depends like whether the blood transfusion we are planning in the antepartum period or the intrapartum or the postpartum period. So when in case of like if they in the antepartum period, mostly if it is like below the hemoglobin level is below 7 and there is any chance of impending heart failure or any decompensation, that is the indication. Or if there is any chance of acute hemorrhage, like acute antepartum hemorrhage if there, then intrapartum also when there is like any when there is the HB is below 6, the hemoglobin level is below 6, that's an indication. And like obvious and with along with chances of decompensation session, so that is an indication. In postpartum also the same, if there is any postpartum hemorrhage, PPH that's occurring, and there is signs of decompensation. So these are the signs like we should go for blood transfusion.
Okay, great. So we have another comment by Dr. Sumita. She says that hapsidine, which is an inflammatory marker, leads to a reduced absorption of iron and can also lead to anemia. So I think we are good to go ahead. Please continue.
Okay.
Come to the airway examination. Inter-incisor distance is more than 3 centimeter. Thyromental distance more than 3 finger breadth. Sternomental distance is more than 13 centimeter. And Malampati grade is 3. Neck movements are normal and there is no loose teeth or dentures. On obstetric examination, on inspection, the abdomen is longitudinally distended, flanks are full, stria gravidarum and linea nigra are present, umbilicus is everted, and there are no scars or dilated veins, and hernial orifices are normal. On palpation, fundal height corresponds to episternum and flanks are full. Symphysis of fundal height is 35 centimeter, abdominal girth is 36 centimeter, and on abdominal grips, there is longitudinal lie with cephalic presentation. On auscultation, the fetal heart sound is heard on the left side below the umbilicus, and fetal heart rate is 145 beats per minute. Coming to cardiovascular system examination, on inspection, the shape of the precordium is normal. There is no precordial bulge or deformity. Apical impulse is not seen. There is no other visible pulsation or engorged veins or pigmentation, and there are no scars or sinuses. On palpation, the apex beat is felt in the fourth intercostal space, lateral to the midclavicular line. There are no palpable pulsations or thrill, and there is no parasternal hail. On percussion, normal findings are noted. On auscultation, first and second heart sounds are normally heard, and ejection systolic murmur of grade 3 is heard in the aortic area.
Dhanlakshmi, can you go back to previous slide, please?
Yes, ma'am.
So what difference in your clinical findings for the cardiovascular examination do you find when compared to non-pregnant patients? And what is particular finding which is quite explainable in this patient?
Yes, ma'am. The apex beat is normally in a non-pregnant patient, it will be in the fifth intercostal space, just medial to the midclavicular line. But in pregnancy, as the gravid uterus becomes an abdominal organ, it pushes the diaphragm upwards, causing cephalad and lateral displacement of the heart. This causes shift of the apex beat to the fourth intercostal space and lateral to the midclavicular line.
Right. And what about
the auscultation findings?
Yes.
Also, like here we are getting a functional murmur, like due to hypodynamic circulation, like ejection systolic murmur we are getting in case of pregnancy.
Which is again normal.
Okay, so what grade would you give to this type of murmur?
Ma'am, mostly like this is like belonging to grade 3 murmur, like according to like
according to Levine's grading, grade 3 murmur is when the murmur is heard easily audible, but there is no associated trill.
Right. So are these benign or these need to be
No, these
even
are,
further evaluated into?
No, ma'am, these are normal
physiological
changes.
flow murmurs.
flow
Normal
murmurs.
flow murmurs.
All right, go ahead, please.
Other systemic examination were unremarkable.
Okay, so pertaining to this cardiovascular system examination, I see a question in the chat box. If Dr. Parul grants me the permission to take up, please. What is the significance of S3 and S4 in pregnancy?
S3 and S4 can also be normally heard in pregnancy.
So these are physiological.
Physiological.
Okay.
In other system, I assume that your per abdominal examination, you were not able to palpate any hepatosplenomegaly.
Yes, sir. There was no hepatosplenomegaly. Also in the respiratory system, there are no crepitations or any added sounds. On GI examination, there is no hepatosplenomegaly or ascites.
Okay. Please go ahead.
On investigating, a patient's blood group was found to be B positive. Her hemoglobin is 7.8 gram per deciliter, which is decreased. Hematocrit is 25%. Again, this is decreased. MCV, MCH, MCHC. Oh, sorry. Mean corpuscular volume, mean corpuscular hemoglobin, mean corpuscular hemoglobin concentration. All of these values are decreased. Red cell distribution width is 16.4%, which is increased. And white blood cell count is 6,500 per cubic millimeter, and platelet count is 3.3 lakh per cubic millimeter. And peripheral smear shows hypocytic hypochromic blood picture, and kidney function test, liver function test, and thyroid function tests are within normal limits. On iron profile, the serum iron levels are 8.8 microgram per deciliter, which is again decreased. Serum ferritin levels are 21.5 micrograms per liter. This is also decreased. Total iron binding capacity is increased, and transferrin saturation is also decreased.
So, what is your provisional diagnosis with this blood profile and your clinical findings of pallor?
So I'll come to the diagnosis of iron deficiency anemia.
So what is the how you define it as a iron deficiency anemia? Means what is the peripheral smear picture?
So the peripheral blood picture is of microcytic hypochromic anemia, so which is generally due to iron deficiency anemia.
So so how you define anemia in pregnancy?
So mostly like anemia
Okay.
is a condition where there is qualitative or quantitative low circulation of hemoglobin concentration, which is below the 2 standard deviation of the median value of a matched healthy population. There are 3 definitions according to this. There is one WHO definition, one is CDC definition, and one is the Ministry of Health and Family Welfare definition. According to the WHO definition, here they're saying the hemoglobin concentration of less than 11 gram percent, or a hematocrit less than 33% in the antenatal period, or a hemoglobin of less than 10% in the postpartum period. This is according to the WHO definition. According to the Ministry of Health and Family Welfare, there's a cutoff hemoglobin below anything below 10 gram per deciliter is known as anemia in pregnancy. And according to the CDC definition, here they say that hemoglobin concentration of less than 11 gram percent in either first or third trimester, or below 10.5 gram per deciliter in the second trimester is defined as anemia in pregnancy.
So we see that you have come down to a diagnosis of anemia. So can you just summarize for the sake of beginning the discussion? Can you summarize all the findings you have made and your impression?
Yes, ma'am. To summarize, we have a 19-year-old primary gravida at 38 weeks of gestation with anemia complicating pregnancy, who is admitted for safe confinement. On examination, there is pallor and mild pitting pedal edema present. On examination, her pulse rate is 98 beats per minute and blood pressure is 108/60 millimeters of mercury. And there is grade 3 ejection systolic murmur or auscultation, and other systemic examinations are unremarkable. And this is a singleton pregnancy with longitudinal lie and cephalic presentation with good fetal heart sound. And the investigation showed hemoglobin of 7.8 gram per deciliter with microcytic hypochromic blood pressure, which is suggestive of iron deficiency anemia.
Right. So, can you just broadly classify the anemias which you can encounter in a pregnant patient?
Dr. Dhanalakshmi, can you hear the question?
I think they have some internet issues.
I think so too. Ma'am, can we take up the points that about S3 and S4? There have been a few queries in the or comments in the text box. They say that Dr. Nagaswamy says that no, S4 is not normal, only S3 is normal. But then we have a Zoom user who says that S3 can be heard in third trimester and S4 in some pregnant patients due to turbulent flow and increased volume, both of which have no clinical significance. And S4 is due to late LV filling due to atrial kick and it's pathological. So, ma'am, what is your opinion about it? Or how do you comment?
In my opinion, also, as for we have had this discussion with our cardiologist also, and they say most of the times, if there like no other features of cardiovascular system involvement and there is in severe anemia, there could be still S4, which is because of volume overload. It could be still there, and because severe anemia itself is pathological, we can't just say it is physiologically seen.
Yes.
Yeah.
So S3 is physiological, S4 is definitely pathological.
But it is due to increased volume, but that range of physiology is not seen in a normal pregnancy. That comes with severe anemia or other causes, maybe cardiac causes, which lead to overload and failure status.
Do we have Dr. Dhanalakshmi back with us?
Which is
Dr. Dhanalakshmi?
I think they must be reconnecting. So meanwhile, we'll just fill in and to continue the discussion.
Sorry for the interruption.
Okay, they're back.
They're back. Good.
Yes.
So, Dhanalakshmi, there's a question for you.
We were classifying the anemias.
Yes, ma'am.
Yes, ma'am.
First, physiological anemia of pregnancy happens because of hemodilution, and the second reason can be because of decreased production of the RBCs. That can be again nutritional and non-nutritional causes. Nutritional can be due to iron deficiency anemia, vitamin B12 and folic acid deficiency anemia, or combined, it is dimorphic anemia. And non-nutritional causes are bone marrow disorders like aplastic anemia, and also other
hereditary causes like
other
thalassemia, sickle cell anemia, or there can be any hemorrhagic causes like the acute antepartum hemorrhage, or chronic due to like any like a hookworm infestation or any like hemorrhoids or anything, or it can be due to anemia of chronic disease, such as if the patient is having CKD or any malignancies or infections such as malaria, etc.
So I'm sure we'll be discussing about the iron deficiency anemia, its severity, and how to manage both the emergency and elective cases and see various aspects. Before we go there, let's discuss some less common causes of anemia. And in short, can you describe your anesthetic management or goals or concerns as far as thalassemia and a pregnant patient is concerned? What is your main point of concern, and how does it change the management?
Yes, ma'am. In a patient of thalassemia, again, the basic pathophysiology behind thalassemia is there is decreased or absent formation of alpha or beta chains. Likewise, there is alpha thalassemia or beta thalassemia. So the major our anesthetic concerns are there is anemia and there is history of repeated blood transfusions, which causes iron overload. And because of the iron overload, that there can be some cardiovascular problems like conduction defects, and also because of volume overload, there can also be congestive heart failure symptoms can also be there. So preoperative evaluation for all these symptoms and signs are important. And intraoperatively, our goals will be to maintain oxygenation if the patient is anemic, and we have to see for signs of decompensation and transfuse blood. And also,
very well said. So I'll just cut you short because this is beyond the scope of this discussion. But the goals remain the same, that we have to maintain the oxygenation. And we should know the specific concerns. And what about the sickle cell anemia and pregnancy?
Ma'am, in case of sickle cell anemia, these leads to a formation of sickle cell hemoglobin due to a point mutation or any missense mutation. Here what happens that there is a clumping of the RBCs. So here this leads to vaso-occlusive crisis. So this vaso-occlusive crisis goes on to when it goes and causes the occlusion of vessels, it can cause decreased oxygen supply, and it can cause pain also. So intraoperative pain management and adequate supply of oxygen is very important when it comes to these patients.
So for instance, you have to prevent sickling in sickle cell anemia. So
yes, sir. Preventing hypoxia, preventing hypothermia, and preventing hypotension. Hypovolemia.
Okay, so you have enumerated several types of anemia. So you also mentioned about physiological anemia.
Yes,
so
sir.
What is physiological anemia of pregnancy?
So, physiological anemia of pregnancy is a normal phenomenon in which there is a rise in the plasma component of the blood by more than 30 to 50% than normal, compared to relative to the cellular component rise, that is of RBCs, like more than 15 to 30%. So as a whole, there is dilutional effect, and this happens that this is physiological because we have to increase the uterine blood flow. Blood flow to the uterus should be more in order to provide blood for the growth of the fetus. So here the blood gets diluted because of that. So this is the reason why there is this physiological anemia occurs during pregnancy.
So does it have any implication? I mean, is it advantageous to mother and baby, or we need to correct this physiological anemia?
No, it is helpful in a way that it will enhance the fetal exchange of gases, as well as it provides a
like during blood loss, it prepares the mother for blood loss, which is to occur either during delivery or during cesarean section.
What about the viscosity of the blood?
Sir, it reduces the blood viscosity because normally it prevents any thromboembolic disorder, like any disorders, or it causes ease of uterine placental blood flow.
So low viscosity enhances the delivery of essential to the elements from mother to the fetus.
Yes, sir.
So if it is physiological, so how does the body compensates for it? What are the compensatory mechanisms that help to overcome it? You had enumerated the reason for the physiological anemia. It is useful, but how does the body compensates for these effects?
So yes, sir. First thing is there is increase in the cardiac output in the mother. By first thing is there is tachycardia, and also increase in the peripheral vascular resistance, vasoconstriction. This causes increase in the cardiac output. thereby enhancing the delivery of oxygen to the fetus. Also, one phenomena that happens is double bore effect. That is, which is the shift of ODC to the left in the fetus and ODC shifts to the right in the mother, thereby enhancing the unloading of oxygen from the maternal blood to the fetal blood, and also enhances the fetal extraction of the oxygen. So this is one more physiological phenomena that happens. Also, there is increase in the level of 2,3 DPG, which also helps in rightward shift of the
ODC and more unloading of oxygen.
So there is increased production of erythropoietin as well.
Yes, sir.
Yes.
So we know that pregnant body is well equipped with handling of anemia. Then why are we worried about this? Why are we discussing so much about this?
Ma'am, anemia to a certain extent can be compensated by the mother, but it goes because the normal physiological anemia, the characteristic is the hemoglobin can go up to 10.5 to 11 gram per deciliter. But if it goes below that, then we have to consider any pathological reasons for anemia. And the concept behind oxygen delivery is the DO2 is equal to cardiac output into the blood oxygen content. So if the oxygen content in the blood is decreasing because of decrease in the hemoglobin, this is compensated by increasing the cardiac output. But as the anemia worsens, the cardiac output, increase in the cardiac output up to 10 liters can be tolerated by the mother. But if it increases further,
Stress
that
on the
causes
myocardium.
stress on the myocardium and causes congestive heart failure.
Right, very well said. So we know that anything beyond the physiology will be stress on the body. So this patient with a hemoglobin of 7.8 gram per deciliter has presented to you for operative delivery or the cesarean section in an emergency setup, like it's an emergency. Then how will you proceed with this patient? What will be your anesthesia management? What will be your goals?
Yes, ma'am. Ma'am, first we would like to go with a very, since it is posted for an emergency section, so we would like to go with a quick assessment of the patient by taking history of the patient and general examination. We'll be taking history, like which is pertinent to the patient, like any history of any cardiovascular.
So we have seen the history, so we know all about it. We have seen the
so
history.
we'll be explaining.
Investigation.
We'll be taking consent from the patient, and like we'll be confirming the NPO status of the patient. We'll be giving anti-aspiration prophylaxis, and we'll be taking the patient for preparing the patient. We'll secure 2 wide-bore cannulas. We'll prepare the OT, keep our emergency drugs ready, and we'll pre-warm the OT, and we'll take the patient in. We'll attach monitors.
Any other investigation would you like to have a look at before you take up that patient? Any other investigation, if available? I know it's an emergency surgery, but there could be an ultrasound abdomen with which you can see whether there is a abnormal placement of placenta, which might lead to further deterioration. You might, if it is available, I know it's an emergency scenario, but maybe while preparing the patient, or there was one done in the emergency setup. If it is done, obviously we have to look at it to see whether there are increased chances of blood loss at the cesarean section. Otherwise, we should not wait for these investigations because the obstetrician has decided to go further. Okay, so what will be your anesthesia technique of choice?
Ma'am, like we'll first we'll go for a blood cross match, and we'll inform the surgeons that there might be like need of blood transfusion. So and after taking the patient inside OT, we'll attach monitors, saturation, blood pressure, and ECG monitors. After that, we'll we'll position the patient, we'll attach oxygen, our anesthetic plan mostly is to avoid hypoxia and minimize all the things that are causing more oxygen demand. Then we will first we will paint and paint and drape the patient, and then we will take give a spinal. We'll go, actually my management here will be spinal anesthesia, single shot spinal anesthesia with low dose drug. We will be mostly here, we'll be taking 0.5% bupivacaine heavy, like around 8 to 10 mg with 25 mics of fentanyl. And this will be my plan.
So, what are the concerns with spinal anesthesia in an anemic patient?
Sir, mostly spinal anesthesia here is leading to sympatherectomy. So there will be hypotension, which will be the issue here, and which is in case of GA, when we are giving the hemodynamic parameters we are able to control, but in case of spinal anesthesia there is profound chance of hypotension.
So in case you had given spinal anesthesia, how you will manage the hypotension, intraoperative hypotension? One thing you had already done is you had chosen a low dose spinal with an adjuvant, but what other measures you can do?
So one more thing is I'll make sure the patient is put in lateral tilt, or I'll keep a wedge under the right hip to make it 30-degree left downwards tilt
to prevent aortocable
compression. And also giving titrated doses of fluid along with phenylephrine boluses. Vasopressors of choice in this patient is phenylephrine. Bolus of 50 to 100 mics titrated to the blood pressure has to be given. And also I'll make sure oxygen supplementation by face mask has to be given.
So you had chosen fluids as well as vasopressors. So why not just fluids only? Any hypotension you initially try to manage with administration of fluid. So why you had chosen a combination of fluids and vasopressors?
So in this patient, especially, again the patient can land up in cardiac overload and failure
because of, is in volume overload.
Because of increased crystalloid transfusion. Also, she might require blood transfusion as well if she bleeds further. So I'll give titrated doses of vasopressor along with fluids.
So basically, what I understand is that you want to avoid excessive fluid administrations to aggravate the dilutional anemia and precipitate cardiac failure in this patient. Okay. So what are the hazards if you find this these are the issues with spinal anesthesia? Why not GA? Why not general anesthesia? Can you go safely with general anesthesia?
So again, in a pregnant patient, the concerns with general anesthesia is, well, first and foremost thing is difficult airway. There are increased chances of failed intubation because of if patient is already in labor, again there can be airway edema, capillary engorgement causes like obstruction in the upper airway, as well as difficult laryngoscopy because of increased breast size, and failed intubation chances are more. And also there is chance of aspiration because of the distended
because of
uterus.
Enterus and progesterone itself causes a decrease in the lower esophageal tone. So that leads to more chances of aspiration.
So it is a known fact that spinal anesthesia is per se more important, the preferred technique for cesarean section in general. So, and this patient, we agree with hemoglobin of 7.8 grams and no evidence of cardiac failure, we can safely go with the spinal anesthesia, keeping in mind not to overload the patients with fluid and manage with vasopressors instead of extra boluses of fluid in case of hypertension occurs. In what scenario would you take up this patient under general anesthesia? What would be a different picture? And what are the guidelines which say?
So mostly if there is any fetal distress, that is the indication, or if the patient is having any decompensated signs of failure, that in that time we are taking under the patient under the general anesthesia. And
what everyone wants to hear is what is the cutoff value of HB that will help you to decide GA versus spinal anesthesia. I think that's a question. And is there any cutoff value or a overall picture?
Mostly there is no specific cutoff value. Like it's all into institution, like there is nothing, it depends from institution to institution. Here, for any normal routine case in our institution, we are taking hemoglobin of 8, but that is not pertinent to any cesarean section case. So it depends on the patient's parameters also, like what is the severity of anemia or what is the severity of the patient. Is the like any signs of decompensation. Even there are cases like in which
okay, let me give you a scenario in which suppose this patient with the similar history had an hemoglobin of 6 grams per deciliter.
Yes, ma'am.
And breathing difficulty in lying down, as well as emergent situation. So how would you go ahead with the anesthesia?
Ma'am.
Ma'am, in this case, as the patient has signs of impending failure and symptomatic anemia, my plan of management will be general anesthesia. Preoperatively, I'll quickly go through the history.
Okay. Yeah.
Immediately. Preoperatively, again, airway examination is important. Quickly go through the records and investigations, and I'll confirm NPO and take informed written consent. I'll also make sure
so we will follow all the routine protocols, which is beyond the scope of this discussion, which is used for general endotracheal tube anesthesia for cesarean section. So we'll follow all that. That's agreeable. We need not discuss all the points because we have to discuss more the anemia part. So how would your fluid administration or blood administration management change in the scenario I had given to you, which was hyper, yeah.
Would you like to? Yeah, please go ahead.
Yes, sir. So as in this case, there is already signs of impending cardiac failure, and also hemoglobin is 6 gram. As soon as I take the patient in, I would like to ask the blood bank to release the
blood
PRBC, packed RBC. So after induction, I'll not overload the patient with fluids. Instead, I'll start off with blood transfusion.
And vasopressor still that is available. Yes, sorry.
No, ma'am. Can I intervene in between? There's a question that what is the minimum hemoglobin for blood transfusion in a preoperatively in a pregnant patient?
I would
Again,
okay, sorry. Please go ahead.
Depending on the trimester, once again, if the patient has less than 34 weeks of gestation and has a hemoglobin of less than 6, we can consider transfusion. If the patient's hemoglobin is more than 6, like 6 to 7, and has symptoms of impending cardiac failure, that is also again indication for blood transfusion. After 34 weeks, if the hemoglobin is less than 7, we will consider transfusion.
Dr. Bharat, you were saying something. I think you wanted to add to something.
No, just I wanted to say that as we had discussed earlier also, that isolated hemoglobin value does not justify for a transfusion. So suppose if the patient is having cardiac pathology, so even that the target of 10 may be desirable. And patients with no other comorbidities with chronic anemia compensate values as low as 7 grams per deciliter. So it is the overall picture that constitutes a transfusion. Anyhow, HB less than 6 grams per deciliter has a high incidence of landing up in failure. So we go ahead for transfusion in such cases. And as rightly said by Dhanlakshmi, the time of presentation decides our goal of management. So it may initially be a medical management with hemodynamics. That also depends on your weeks of gestation, whether it to be an oral preparation or an IV preparation. And in scenarios like this, when they present at terms for in emergency landing section with low HB, even transfusion gets priority over IV parenteral administration.
I think
Okay.
Dr. Dhanlakshmi has very well answered this question.
Yeah.
Dr. Ma'am, you were saying something?
Yeah, so we are talking about the fluid administration. Can you, any one of you, comment upon the use of colloids, especially in anemics like 6 grams per deciliter or 7, or maybe even our patient with 7.8? Can you just comment on the use, the pros and cons of colloids?
Ma'am, the role of colloids, if my patient has ongoing blood loss on table and release of blood products is awaited, in that case, I instead of overloading the patient with crystalloids, I'll consider giving colloids just to maintain the hemodynamics at that point of time. Otherwise,
wait for the blood to be released, so that as soon as the blood
And because the patient is already in a, the vascular volume is adequate, or maybe there is an overload because of the anemia, it's better to use vasopressors and rely more on blood products rather than going for excessive dose of crystalloids. And colloids lie somewhere in between because they have a drawback of causing renal dysfunction in excessive dose. So we can just tide over the time because it's an emergent scenario. We might not have blood in hand if we have to rush the patient for the cesarean section. Then we can use it to tide over. Otherwise, if we have blood in hand or the situation is not that grave, not major blood loss is happening at that time, we can surely avoid colloids. And it is mainly to buy some time and obviously not to use in more than recommended doses, because these patients with colloid overload or otherwise overload are more prone to acute renal injuries as well.
Yes,
Ma'am, what about co-loading? Like we cannot go for preloading, but can we go for co-loading? Anything to say about it?
Okay, so as in non-anemic pregnant patients or the patients with just the physiological anemia, we can go with co-loading, but obviously co means that as the process is going on, procedures are going on, we give some, but we don't transfuse a lot of crystalloid. We just go down on the volume and manage more with the vasopressors. Maybe boluses or infusion is also a better way to manage and have a better control, easy to titrate.
And colloids can also be given during co-loading.
Yes, there's no contraindication, but of course it is more important that if required, then we directly give the blood products or the packed cells for these such patients.
Please go ahead with us.
Gopal, just I would like to ask you, you mentioned regarding administration of GA. So Dhanlakshmi already told about the difficult airway.
Yes.
What other things comes in your mind while managing a patient in GA, an anemic pregnant patient in GA?
So mostly like other than the airway here we are the hemodynamic parameters are in our control. Like mostly we can maintain the hemodynamics of the patient. We can start patient on any like vasopressor or any any thing that manages the hemodynamics, or there is
respiratory advantage,
and
you can go as you can answer stepwise. Means what are your concerns? You discussed about intubation, your concerns during induction.
Yes, sir.
Your vitals during your intraoperative, and your post-operative, what you would like to prevent. So with respect to induction, any specific with respect to pregnant patients?
So here we'll be following like modified RSI here, like while intubation, we'll be giving titrated dose of induction agent, reducing propofol 2 mg per kg, followed by either suxamethonium 1 to 1.5 milligram per kg, or rocuronium in the dose of 1 to 1.2 milligram per kg. And will be securing the airway using appropriate size ET tube. And
so basically, when you are inducing, you would like to prevent precipitous fall in
BP,
pressures,
hypotension.
because cardiac output is increased, and that is maintaining the oxygen delivery. So
Yes.
you don't want to have a precipitous fall in the cardiac output. So gradual induction, and before that, ensure pre-oxygenation. We do it, but it carries more with context because of difficult airway and increased oxygen requirement.
Okay, Dhanlakshmi, what are the obstetric complications which are commonly observed in patients with anemia?
Obstetric, there can be antenatal and intrapartum and postpartum complications. Antenatally, there is increased chance of preeclampsia, eclampsia in these patients, and also because of also in the intrapartum, there is again increased chance of PPH, and postpartum hemorrhage is also more in these patients.
What is the reason for increase in PPH, incidence of PPH?
Because of uterine atony.
Right.
So, Gopal, you had just started regarding the induction part. We
Yes.
had discussed pre-oxygenation, slow induction.
Yes.
What else you would like to monitor? What will be, whether we would like to use nitrous oxide or not?
Sir, mostly like, sir, we'll be keeping like 50% air oxygen mixture with sevoflurane here. Nitrous oxide, like mostly in patients, we'll be very cautious where there is folate or like vitamin B12 deficiency, as using nitrous oxide can cause problems here. Or like mostly we'll be keeping at the time of induction, we'll be keeping a minimum alveolar concentration value around 0.8 to 1. Around after the delivery is after the baby is out, we can we have to decrease the MAC value to around 0.5 to 0.6, and we can administer like fentanyl, 50 mics fentanyl or the midazolam in order to prevent intraoperative awareness in this patient, as since the increasing the inhalation agent can cause uterine atony itself. So that will prevent the blood loss due to PPH. So that will be our like.
There is no, if there is no vitamin B12 or folate deficiency, can you use nitrous oxide in this?
Yes, ma'am. We can
What
use
will be the
nitrous oxide.
advantage? What will be the advantage?
We can use nitrous oxide, ma'am, if there is no folate or vitamin B12 deficiency. But like.
What will be the advantage of nitrous oxide?
Ma'am, using nitrous oxide will cause like decrease in the usage of the volatile anesthetic by causing concentration effect, second gas effect, as a result of second gas effect. So that will cause the reduction of the inhalation agent consumption, and like it will mostly it is very good analgesic as well. And like mostly for labor analgesia, we're giving 50% oxygen and nitrous combination Intonox. And the disadvantage can be that use of nitrous oxide will lead to post-operative nausea and vomiting, and that is one reason. And mostly nitrous oxide, like in our institution, we're using air oxygen mixture with sevoflurane.
Okay. And what are the fetal complications of anemia in pregnancy?
Ma'am, there can be intrauterine fetal growth restriction can be there, or there can be like
there can be preterm delivery, IUGR, and also perinatal mortality will be increased in the babies.
So, Gopal, you were emphasizing on analgesia and depth of anesthesia.
Yes, sir.
So, is the pregnant patient different with respect to vitals parameters like heart rate or the blood pressure compared
Yes,
to
sir,
a
the heart rate of
non-pregnant?
the heart rate of the patient will be on the higher side. This is because this is a compensatory mechanism to cause more oxygen delivery to the fetus. So the heart rate will increase. So that's normally there will be a heart rate which is for a normal non-pregnant patient. It might be seen that it's tachycardia, but this is normal in case of this patient, because that is because just it's a compensatory mechanism which is providing more oxygen for the fetus.
So you guessed it right. It's just that a slight amount of tachycardia or the wide pulse pressure should not be taken as a lighter plane of anesthesia or inadequate analgesia.
Yes, sir.
And with regard to your, you said that I don't want to increase the oxygen demand. So what all other things you will ensure intraoperatively?
So we have to prevent hypothermia and also
Acidosis.
pain, any factors which causes acidosis, pain, shivering, fever. All of this will increase the oxygen demand. So these factors has to be taken care of. Even in the post-op, we have to keep the patient warm. If there is shivering, we have to supplement oxygen and treat all these factors.
So in mechanical ventilation also you need to ensure that you do not induce respiratory alkalosis.
Hyperventilation.
Will prevent hyperventilation.
So normocapnia should be ensured. Otherwise, again, it will shift the ODC curve.
ODC to the yes, sir.
All right. Okay. Suppose now this patient came for easy fatigability, but obstetricians decide that she can still wait for a cesarean section or the termination of pregnancy. That means it's an elective scenario. So how will your management change for this patient who has presented at 37, 38 weeks pregnancy? And what if she had come at 34 weeks? What type of supplementation or management of iron deficiency anemia?
Mostly in the
if the now the patient has presented at 36 weeks.
Yes. So there's still like maybe 3-4 weeks for the obstetricians to go for termination of pregnancy.
Yes, ma'am. At this point of time, again, depending on the severity of anemia, if it is moderate and severe anemia, we have to go for parenteral iron therapy in spite of oral therapy in these patients. And if it is severe anemia more than 36 weeks, again, we will consider between parenteral and blood transfusion, depending on the symptoms.
So can you elaborate more on the parenteral iron therapy and how much is the requirement and how do we calculate the dose and what are the preparations available?
Yes, ma'am. Normally in a pregnant patient, the requirement of iron will increase for the development of fetus in placenta, for RBC volume expansion in the mother itself, and also to balance the losses. Approximately there will be 1000 mg of iron requirement throughout the pregnancy. In the first trimester, it will be approximately 2.5 milligram per day requirement. In second trimester, 5 to 6 milligram per day, and third trimester it will increase up to 10 milligram per day. So coming to the parenteral preparations, we have IM as well as IV preparations. IM, there is iron sorbitol citric acid and also iron sucrose, which is available in 100 ml vials, which can be at once we can give 100 mg dose. Can also be increased up to 200 mg per dose. But the again, the drawback of iron therapy is there'll be pain, tenderness at the site of injection, staining, and also abscess formation is also there. So other preparations which are available, IV are iron sucrose, iron dextran, iron carboxymaltose, iron isomaltose, all these preparations. And with the use of iron dextran, the chances of anaphylaxis is more.
So when do you hope to get the response from iron therapy? Means how to monitor the response?
either with oral or parenteral therapy, within a 1 week of therapy, there will be improvement in the hemoglobin up to 1 milligram per week. 1 gram,
First,
sorry,
there will be
1 gram
improvement,
per 1 gram per deciliter per week.
First, there will be some improvement in symptoms, like the patient will tell that there is relief in the fatigability and everything. They will change first, like there will be response in the clinical signs first. Then, as she said, sir, that there will be increase in the hemoglobin level of 0.8 to 1 gram per deciliter per week.
But the response is usually seen after 3 weeks. The increase in HB so initially there is a symptomatic improvement and later. Okay.
So I think we have discussed most of the points for both emergency and elective surgical scenarios, and give them all the possible scenarios of even further low hemoglobins. And in my opinion, they have done justice to the topic, and it's, with your permission, Dr. Parul is open for discussion. Anyone else?
Yes, ma'am. Ma'am, we have some comments and questions. Can I go through them with your permission?
Yeah, sure.
What is the safe level of sevoflurane in these patients?
Safe levels, ma'am?
Yeah, that is the question. What is the safe level of sevoflurane? Most probably, I think they want to know what will be the level which will not lead to relaxation of the uterus, so that there's no, it doesn't cause bleeding more.
Ma'am, mostly
how much MAC of sevoflurane is recommended for these patients?
Ma'am, 0.8 MAC is
And
studies have shown that Hello, ma'am. Studies have shown that 0.8 MAC of sevoflurane does not cause any uterine atony, but like that after the baby is out, like 0.6 to 0.8 MAC of sevoflurane is safe and it will not cause uterine atony.
And the second question is, what is the reticulocyte count in these patients? Is it increased or is it decreased? Let's go with that first.
After starting the therapy, the reticulocyte count will increase from 10 to 15%.
Because there's a decrease in the hemoglobin synthesis. So how to calculate the dose of iron therapy when planned to give IV or IM?
Ma'am, this is according to the Ganzoni formula, which goes as the body weight, pre-pregnancy body weight of the patient, multiplied by the hemoglobin deficit. That is the targeted hemoglobin minus the actual hemoglobin into 2.4 plus the plus 1000. So this is the total iron which is required in order to give the patient.
Right. So what are the side effects of different types of vasopressors that are routinely used? Anybody would like to answer that? What are the side effects of different types of vasopressors that you routinely use?
Ma'am, routinely we use mefentermin. Also phenylephrine and ephedrine can also be used. Mefentermin causes tachycardia as well, along with increasing the BP. And phenylephrine, there's an advantage that there is no tachycardia. Like in comparison to ephedrine, especially in pregnant female patients, ephedrine can cause fetal acidosis by crossing the placenta. So this doesn't happen in phenylephrine. Doesn't cross the placenta, and
what about the noradrenaline? Because nowadays prophylactic infusions of noradrenaline versus phenylephrine versus ephedrine, everything has been studied. So what, in your opinion, is the best according to the current evidence?
Ma'am, if there is like to manage any transient episodes of hypotension, it's better to go with bolus dose of phenylephrine, or in a case of like any patient with cardiac disorders, in order to maintain the BP, where we are not administering more amount of crystalloids or colloids, we can start off with noradrenaline infusion.
So we finished well on time, and I should commend the way Dr. Dhanlakshmi and Dr. Arvind have answered. And as an external examiner, if I would have been there, I would have given them very good marks. So, and thank you so much, chairpersons. We have a question by Dr. Madhuri Kurti, ma'am, or a comment. Ma'am, please unmute yourself.
I'm already unmuted.
Yes, ma'am.
Yeah. So heartiest congratulations to Bharat sir and Swati ma'am for an excellent presentation on pregnancy and anemia. And as she said, she has covered most of the questions that are asked on this topic. And congratulations to the students too, Dr. Dhanalakshmi. And yeah, so this Dhanalakshmi, with the permission of the moderators, can I ask
Please
a
go ahead.
question?
Grill them.
Yeah. So this you said that have you elicited the history of vomiting, hyperemesis? Have you elicited the history?
In the first trimester, we have
Yes.
mentioned
There was
no
no
Yes, so
history of-
that is one condition which can lead to severe anemia in pregnancy.
Again, that
Then
can cause
even if-
decrease
yes.
in dietary intake.
Exactly. And even if there is a twin pregnancy or if it's a very young primary gravida, then the chances of anemia are going to increase.
Yes,
Now,
ma'am.
one question to you is, suppose this, will you advise labor analgesia in this case? Is it indicated?
Yes, ma'am, definitely, ma'am.
Why?
So, the advantages of labor analgesia, especially in this patient, is there is advantage to the mother as well as fetus. In mother, normally during labor, because of
Labor
pain,
pain.
there will be sympathetic response, causes tachycardia, which
Increase in
increases the
oxygen
oxygen demand, and pain itself can increase the oxygen requirement, and also there will be hyperventilation followed by like period of hypoventilation as well. When there is hyperventilation, this causes shift of the ODC curve to the left, decreases the oxygen delivery to the tissue as well as fetus. So also thereby labor analgesia helps to the mother as well as the fetus.
So what is the double bore effect and how it plays a role here?
Ma'am, double bore effect, basically it will improve the oxygenation to the fetus. So what happens is in the fetal circulation, there is production of CO2 that the CO2 will get
down the
transfer from the
gradient, concentration gradient.
fetal side to the maternal side of the placenta. So there is alkalosis of the fetal blood and acidosis of the maternal side of the placenta. So shift of ODC curve happens to the left in fetal blood, and it happens
Since
to
the
the
mother's
right
blood
side.
become more acidic, so it will cause more
Exactly.
release of-
Is there any other effect, just like the double bore effect? Is there any other effect which is applicable here? Just because you are talking of CO2, no?
Yes, ma'am. Ma'am, CO2, matlab Haldane effect happens in the lungs, basically.
Lungs. Right. Okay, but one more thing of labor analgesia is it will prevent the tachycardia, and so the chances of patient going into cardiac failure will be less, isn't it?
Yes, ma'am.
Okay, yeah, well done, very well done.
Thank you.
Madhuri ma'am, this answers the question which one of our audience has also asked. Dr. Nagaswamy, may I request Dr. Nagaswamy to unmute himself and ask the questions?
Yes.
Dr. Nagaswamy, are you there with us? I think, ma'am, he is logged out. So, do we need to have
question? What was his question?
Ma'am, the same question which you asked him.
What was that?
Ma'am, about yes, ma'am, the Newtonian fluid and non-Newtonian fluids, and about the Le-Chatelier's principle with the double bore effect. How does it help? So the kids have answered it very well.
Okay,
So,
done.
can we go on to the next question? Do we need invasive lines for the patient in cardiac failure due to anemia? And if so, is it indicated?
Yes, ma'am, definitely indicated.
But I would like to add, if it is an emergency scenario, we should just first address the delivery of the baby, and then if required for further management, maybe in ICU or something, then we can go ahead. It's depends on the urgency or emergency situation if it is there.
The patient in failure is unlikely to be extubated. You will be conducting it under general anesthesia. So patient is unlikely to be extubated on the table. She might require some amount of post-operative mechanical ventilation. So repeated blood gas sampling will be an added advantage in addition to the intraoperative hemodynamic monitoring. So the effect of your intraoperative measures will be reflected by your serial ABGs, intraoperative ABGs, as well as it will help you monitor the HB in the post-operative period as well. So definitely in a patient with cardiac failure, arterial line will be helpful.
Right, sir. So we have some seniors here with us. May I ask Dr. Naveen Malhotra, sir, would he like to add something or share his experience with us? I think sir is not able to connect with us. Can we have Madhuri ma'am?
Yeah.
I think we've answered most of the questions.
Yes, we have answered most of the questions, and I think Bajwa sir is online.
Bajwa sir, may I request you to kindly conclude the session and give closing remarks?
So whatever it is, when you get a case of pregnancy, it will either be anemia, valvular heart disease, or it's going to be PIH. And labor analgesia may be discussed. And the physiological changes of pregnancy, everything you should be fit back with all those, right? Yeah.
So ma'am, with your permission, can I conclude the session? Madhuri ma'am?
One sec. I think sir is online. Sir is online.
I just had a meeting actually going on, came out of the meeting room. I think everything went well. Today, apologies for not attending the class. And Dr. Madhuri, I think you must have handled everything. I expect that part.
Yes.
Any doubt left? Just ask me the doubt. Any doubt left?
Hello?
No doubt.
No doubt, sir. A lot of it has been discussed.
Yeah, that's why the meeting was still going on. I came out from the meeting, a very important meeting going on.
No
so,
doubt.
but start the half an hour back only. I listened the first part, the presentation, and that part later on got a little busy. I think if everything is good, so I think kudos to the Jodhpur team, the residents, and Dr. Swati and Dr. Bharat. And equally,
We would
you
like
can
to
see me
thank you,
sweating
sir.
also. You can see me sweating as the meeting is going on in a different circumstances. And I think whatever has been done today, anemia and pregnancy was my favorite topic. I would have loved to attend the whole, but real apology, I could not attend. So I will get the feedback on the YouTube. I will watch also, just like other PGs they watch on the YouTube. I will be watching it on YouTube at night. So goodbye from my side and all the best to all the people. Please, excuse me for thing. I think Dr. Madhuri and Dr. Parul will take care of proceedings. Both the PG residents, kudos to you for the today class. All the best and best wishes for your future examination also.
Thank you.
Okay, and congratulations your teachers also who prepared you very well. Okay,
Thank
bye.
you, sir, for inviting
Bye
us.
from my side. Bye.
So thank you, Bharat sir. Thank you, Swati ma'am. Thank you, my dear postgraduates, and thank you, Parul, for conducting the session. Thank you, Nishant, and thank you to the entire team for the good presentation. So good night and long live I say.
Long live I say. Good night and thank you.